Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering schizophrenia, and schizophrenia is very, very heavy. That one disorder takes up a whole chapter, so this is going to be a multi-part series. Now, before we get started, I'm going to ask you to please support me, support my channel by liking this video. Do it now so you don't forget. Like my video, subscribe to my channel if you haven't done so already. And don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. Make sure you guys check that out. Now, when I do teaching, I'm always asked what book I'm using. For this particular disorder, I'm going to be using this book. I'm not going to pronounce the author, but this is the book, Foundations of Psychiatric Mental Health Nursing, 8th edition. This is a wonderful book. So if you're struggling with psych or mental health, I would encourage you to check that out. And guys, I wish I did, but I don't. I have no endorsements. So I'm just telling you this because it's the truth. Nobody's paying me to say this to you. All right, let's get started. So schizophrenia. Oh, I need to get my notes. I took them off yesterday. It looks crazy. I'll point with my pen. So look what it says. It says schizophrenia spectrum disorders are disorders that share features with schizophrenia. Before we even get into this, you need to know when it comes to schizophrenia, these patients are out of touch with reality. When you see that word psychosis, that means to be out of touch with reality. These disorders are characterized by psychosis, which refers to altered cognition. What is cognition? The way you think. So the way that they think is altered. Altered perception, the way that they process stimuli, that is altered, and or an impaired ability to determine what is real and what is not. So they may see things that are not really there. They may hear things that is not really there. They may have false beliefs, okay? Delusional disorder. Delusional disorder is characterized by delusions that have lasted for 1 month or longer. What's a delusion? A false belief. The delusions tend to have general theme that includes grandiose, thinking of yourself higher than everyone else, or thinking that you have a special power, like you can speak to God or you are a God, right? Persecutory, when you feel like you're being attacked, you're being singled out, you're being persecuted. Somatic, when patients have a somatic complaints, guys, so they may have physical manifestations of something that's psychological. And what does it say? Referential delusions. I gotta look that up. I don't know. Referential. I know delusions of reference, but I don't know if that's the same thing as referential delusions. And I don't want to tell you the same thing, so I gotta get back to you on that. Let's keep going. Schizophreniform disorder. The central features of this disorder are exactly like those of schizophrenia, except that symptoms last for a much shorter period of time, less than 6 months. Let me make this a little bit bigger for you guys. Also, impaired social occupational functioning during some part of the illness is not apparent, although it might occur. Now, those patients that actually have schizophrenia, they have that disorder, this is chronic, this is ongoing. They have impaired social occupational functioning, because who's going to have a long-lasting social or even social relationship or even a career when they're hearing things that are not there or they're seeing things that are not there, okay? So with schizophreniform disorder, it lasts for a much less amount of time. So seeing those relationships break down or the career breakdown, it's not as prevalent as you would see with someone with the actual schizophrenic disorder. It's difficult to know the prognosis of schizophreniform disorder because some individuals return to their previous levels of functioning. Remember, they have this for like 6 months or less, while others have more difficulties in moving forward. All right, so let's look at schizophrenia. Let's look at the clinical picture. Is my light on? Okay. Prodromal phase. Okay, people who later develop schizophrenia often experience the prodromal phase, during which some milder symptoms of the disorder develop, often months or years after that disorder is fully apparent. During the prodromal phase, the person may do less well in school than his or her peers. They may be less socially engaged or adept. They may demonstrate memory impairment. suspiciousness, disorganization, or oddities in speech or thought. So everything was good up until then. Now we're starting to see these clinical manifestations. All people diagnosed with schizophrenia have at least one psychotic symptoms. Remember, that word psychotic means to be out of touch with reality. They have at least one psychotic symptom, such as hallucinations, delusions, and or disorganized speech or thought. Let's take a look at the Dsm-5 criteria for a patient to be even diagnosed with schizophrenia. They have to have 2 or more of the following, each present for a significant portion of time during a 1-month period. At least one of them have to be delusions, hallucinations, disorganized speech, such as frequent derailment or incoherence. You can't even understand what they're saying. It makes no sense. Or grossly disorganized or catatonic behavior. Let's look at comorbidities. What other diagnoses do we tend to see with this disorder? Substance use disorders, cocaine, alcohol, anxiety, depression, suicide, physical illnesses. Take a look. The risk of premature death due to medical illnesses is 3.5 times greater than that in the general population. And on average, patients with schizophrenia die more than 20 years prematurely. And guys, I haven't even looked at the scientific research behind this, but one thing I do know with the patients with schizophrenia, they're not very trusting, including doctors and healthcare professionals. So it's not like they're going in to get themselves checked. It's not like they're taking their medications. So they let things go. And when you let things go physically, you get sick and you don't address it. So I'm sure that has to do with them dying 20 years prematurely, and with medical illness 3.5 times greater, because they're not getting things checked up. Because one of the things with schizophrenia is they tend to be very distrustful and very paranoid of everyone. Okay. Polydipsia. Polydipsia, this is compulsive drinking of excess fluids. So they're drinking a whole lot of fluids. It occurs in up to 20% of individuals with schizophrenia, and it causes hyponatremia. Remember, your sodium is supposed to be 35 to 45, right? And remember, sodium is a very important electrolyte. Patients should not have hyper or hyponatremia. But with the patient with schizophrenia that's drinking all of this fluid, what happens? They dilute the sodium that they have, and they cause themselves to have fluid excess, fluid overload. Symptoms include confusion, delirium, hallucination, worsening of existing psychotic symptoms, and ultimately they can go into a coma. Okay, let me move this camera. Risk factors for schizophrenia. The diathesis stress model is probably the best explanation for the existence of this disorder. Schizophrenia occurs when multiple inherited gene abnormalities combine with non-genetic factors. So what does this tell us? This tells us when it comes to schizophrenia, it's not just genetics and it's not just environmental, it's a mixture of both, okay? These factors include viral infections, birth injuries, environmental stressors, prenatal malnutrition, abnormal neural pruning that alters brain development and neural function, or injury to the brain directly. And what did I write down here? I wrote there are many theories, but no one really knows exactly what causes it. Let's talk about the neurobiological first, the dopamine theory. And we're calling it theory because in reality, we honestly don't know exactly what causes it. Okay, so the dopamine theory. The first antipsychotic drugs, known as the first generation typical antipsychotics, such as, your Haldol, they block the activity of dopamine receptors in the brain, and they reduce symptoms such as hallucinations and delusions. Look at what it says. Symptom reduction suggests that dopamine plays a significant role in psychosis. We can't prove it yet, but that's what the thought is. Amphetamines and cocaine can induce psychosis in people without schizophrenia and can also bring on the disorder. Almost any drug of abuse, especially marijuana, can increase the risk of schizophrenia in biologically vulnerable persons. And that's why you should ignore when people say, oh, well, marijuana came from the earth, it's not harmful. It does have the potential to be harmful. We have to be careful with that, okay? Other neurochemical hypotheses. Second generation antipsychotics, they block serotonin and dopamine, which suggests that serotonin may play a role in schizophrenia as well. I'm not going to try, I guess I am going to try to pronounce this. Phencyclidine, that's PCP. Not good. That's why I wrote it here. No good, no bueno. Put a sad face, okay? PCP, glutamate dopamine, also not good. And serotonin acts synergistically in neurotransmission, and thus glutamate may also play a role in causing psychosis. Again, all of these are theories. Let's talk about prenatal stressors. Infection during pregnancy increases the risk of mental illness in the child. Other factors associated with increased risk of schizophrenia include a father older than 35 at the child's conception and the child being born during late winter or early spring. Why? I have no clue. But we found that to be a pattern, a trend. Psychological stressors. Schizophrenia often manifests at times of developmental and family stress, such as beginning college or moving away from one's family. I put a star next to that because if you happen to get a question about schizophrenia, this is usually one of the ones they ask, when do we see this most often? So we'll see that, and we see this more in males than females. The person will be just fine. They go off to college in about end of sophomore, maybe about junior year, things start to change and we start seeing these clinical manifestations sometimes as early as freshman year. Social, psychological, and physical stressors may play a significant role in both the severity, how bad it is, and the course of the disorder and the person's quality of life. Other risk factors: childhood sexual abuse, exposure to social adversity, chronic poverty, migration to or growing up in a foreign culture, and exposure to psychological trauma or social defeat, being the oddball, being the outcast, being bullied. Environmental stressors. Environmental factors such as toxins, including the solvent. You guys see it. I'm not going to try to pronounce it. But this solvent, you find it in like dry cleaning, line water pipes, sometimes in drinking water, right? It's believed to contribute to the development of schizophrenia in vulnerable people, people who are already genetically predisposed to it. Living in urban areas or high crime environments is also believed to increase the risk of schizophrenia. Let's talk about the phases of schizophrenia. Okay. So prodromal phase, we start to see mild changes in their thinking, reality testing and mood, insufficient to meet diagnostic criteria. So it's not as bad that, remember the DSM-5 I just showed you? It's not that bad yet that they meet that diagnostic criteria, but we're starting to see those clinical manifestations. The symptoms appear a month to more than a year before the first full-blown episode of the illness. So during the prodromal phase, speech and thought may be odd or eccentric. They start becoming weird. And I don't mean to be disparaging when I say the word weird. I'm just using that word to kind of help you understand what it looks like, okay? Anxiety, obsessive thoughts, and compulsive behaviors may be present. Deterioration in concentration. We start to see the grades start to go down. The person who used to be very active in all these clubs start not showing up or not, fulfilling their responsibilities. They don't focus as much as they used to. School or job performance deteriorates. Social functioning are accompanied by distressing thoughts, suspiciousness, memory impairment, and disorganized speech or behavior. Now we move to the acute phase. Later symptoms vary from few and mild to many and disabling. So they're so bad now, the patient might not even start to go to class anymore, or they stop going to work. Symptoms such as hallucinations, delusions, apathy, social withdrawal, diminished affect, and hedonia. That's when they don't find pleasure in things that they used to find pleasure in. Disorganized behavior, impaired judgment, cognitive regression result in functioning impairment. And because of that functioning impairment, like I said, that's when they drop out of school, stop going to work. Stabilization. Symptoms are stabilizing and diminishing, and there's movement towards a previous level of functioning. They go back to their baseline. Maintenance or residual. The condition has stabilized and a new baseline has been established. Positive symptoms, and you guys are definitely going to have to know the difference between positive and negative symptoms. Positive symptoms are usually absent or significantly diminished, but negative and cognitive symptoms continue to be a concern. So let me just explain this to you now, and then we'll go over it again later. So positive symptoms, in the maintenance or residual phase, we really don't see positive symptoms. Positive symptoms are symptoms that the patient has that they shouldn't, such as hearing voices or seeing things. Negative symptoms are the symptoms that the patient should have, but they don't. Okay, we'll go over those later. But what's important to know now for the maintenance or residual phase, those positive symptoms that the patient has that they shouldn't, we really don't see much. But the negative symptoms we still see, which are things we should see in them that we don't. All right, so general assessment. Positive symptoms. This is the presence of something that should not be present. So a positive symptom is something that the patient has that they should not. Hallucinations. Are you supposed to have hallucinations? No. So that's a positive symptom. Are you supposed to have delusions? No. That's a positive symptom. Are you supposed to be paranoid? No. That's a positive symptom. Disorganized or bizarre thoughts, speech. Those are positive symptoms. Having something that you should not. Negative symptoms. That's the absence of something that you're supposed to have. So what are negative symptoms? Inability to enjoy activities. Remember that A word I couldn't pronounce, and anhedonia? That's what they're talking about. That is a negative symptom. Social discomfort, lack of goal-directed behaviors, okay? And I added this onto the side because it's not in the book, but NCLEX has asked about this before, so you need to know that. Affective flattening, that is a negative symptom. All right. Cognitive symptoms. Remember, cognitive, that's how you think. Subtle or obvious impairment in memory, attention, thinking, problem solving, judgment. And last, affective symptoms. These are symptoms where emotions are expressed, okay? Affective symptoms, symptoms involving emotions and their expression. So if I'm happy, you should see on my face that I'm happy. If I'm annoyed with you, you should see on my face that I'm annoyed with you, right? So that's affective symptoms. You can see their expression. You can see their emotions from their facial expressions. Let's get into more of positive symptoms. Let's get to alteration and reality testing, actually. Let's talk about this. Reality testing. This is the automatic and unconscious process by which we determine what is real and what is not real. So for example, you think you hear a voice, but you see that no one's present. So you're like, okay, you know what? That was just me, right? You conclude you were mistaken. It wasn't real. With impaired reality testing, the person believes that the hallucinations or delusions are real. So they have impaired reality testing. And like I told you before, delusions are false beliefs. Delusions are false beliefs held despite a lack of evidence to support them. So you have that false belief and nothing to back it up. Matter of fact, you may have a false belief and you have proof to the contrary, but you still believe that false belief, okay? The most common delusions involve persecutory, everybody's out to get me, grandiose thinking, I have special powers, or religious ideas. Now let's go back down here because I want to go over this with you. You guys need to know the difference between negative and positive symptoms. I promise you, if you're in the taking psych right now, you're going to get at least 1 or 2 questions on this. So again, positive symptoms are symptoms that the patient has that they should not, such as hallucinations, delusions, bizarre behavior. Negative symptoms are symptoms that the person that doesn't have that we expect to see. What are they missing? Okay. Poverty of thought, loss of motivation, inability to experience pleasure. You see that? They're missing something that should be there. Blunted affect. Your affect should not be blunted. If I'm happy, you should be able to tell. If I'm annoyed, you should be able to tell. So make sure you guys know the difference between those two. All right, let's talk about alterations in speech. And you know it's important because I said no with 3 exclamation marks. Okay, one of the most common associative looseness or looseness of association results from illogical thinking. Look at this, guys. Concentration is poor and individuals loosely associate their thoughts together. It still makes no sense. Look at this. For example, I need to get a Band-Aid. My friend was talking about AIDS. Friend talk about French fries, but how can you trust the French? It makes no sense. Those words are loosely associated, okay? Word salad. This is the most extreme form of associative looseness. It's a jumble of words that is meaningless to the listener, such as throat horse strength of policy highlighters on a boat reigning supreme. What is that? Clang association. This is choosing words based on their sound rather than it making any sense. So an example, on the track, have a Big Mac, click, clack, clutch, close. Neologisms. These are words that have meaning for the patient, but a different or non-existent meaning for others. A person may use a known word differently than others understand it, or they might create a completely different word that only they understand what that means. Such as the person saying Mannerlugis are poor. What the heck is a Mannerlugi? The person who made up the word knows what the Mannerlugi is, but nobody else knows what that means. Echolalia. This is a pathological repeating of another's words occurring perhaps because a patient's thought process is so impaired that they're unable to make their own speech, okay? Pressured speech. This is an urgent or intense speech. It resists allowing comments from others. So they're talking a mile a minute, and it's called pressured speech because they're pressuring those words out, and they're talking so much. They're not even giving the person that they're talking to a chance to respond or get one word in. That's pressured speech. Flight of ideas. Moving rapidly from one idea or thought to the next. And so it makes it hard for the person that they're having the conversation to even follow because you're moving from one idea to the next and you're not linking it together. It makes absolutely no sense. Paranoia. This is an irrational fear, ranging from mild, being wary, being guarded, to profound, believing irrationally that another person is trying to kill you. The fear may result in defensive actions harming another person before that person can harm the patient. So that paranoia might be so bad, they might injure somebody because they feel like, well, I have to hurt them first before I give them a chance to hurt me. Hallucinations occur when the person perceives a sensory experience for which no external stimulus exists. So they hear something, but there really was no sound. They see something, but there's really nothing there. And there's all different types of hallucinations: auditory, that's a hearing; visual, that's a seeing; olfactory, that's smelling something that's not there; gustatory, that's tasting, that's experiencing tastes that do not exist; tactile, feeling bodily sensations that don't exist, such as feeling animals crawling on them and there's nothing there. Criminal Minds actually had a great episode on a group of people that had tactile hallucinations. Auditory hallucinations, the most common form of schizophrenia, are experienced by more than 60% of people with schizophrenia. That's seen many times on NCLEX, has seen ATI. Make sure that you know it. Auditory hallucinations. They're the most common type of hallucinations that we see in schizophrenia. Now, let's look at this table that goes over the types of delusions. Remember, guys, when we talk about hallucinations, that's seeing or hearing or tasting things that are not there. Delusions are beliefs, having beliefs that are just untrue. So the persecutory delusion is believing that they're being singled out, that they're being persecuted. Grandiose, again, that's believing that they're more important than other people. They have a special power. They have a special connection that other people don't have. By the way, I'm sorry I didn't mention this earlier, but if you're new to my channel, anything that you see I put a star next to, you're likely to see that on a test at school. Anything that you see I either put HESI, ATI, or NCLEX next to, that means most likely you're going to see that on HESI, NCLEX, or ATI if you happen to get a question on that particular subject. Because something you guys have to understand, these exams, there's exams at school, the third party exams such as your ATI or your HESI, they all follow NCLEX because the whole point is for you to pass NCLEX. So whether you see I write ATI, HESI, whatever, just know that they're following NCLEX. So if I put a star or I put one of those, that means it's important for you guys to know. Make a notation. If you don't understand it, go read about it in your textbook. Make sure you have a firm knowledge of what it is that I put a star next to. All right. Patients may attempt to cope by drowning out auditory hallucinations with loud music, or by competing with them by talking loudly, humming, or singing. They're trying to get rid of those voices, okay? Such auditory competition may in fact reduce hallucinations and serve, look at this, guys, as a recommended intervention. And this is often recommended where that patient's hearing the voices, that they're taught to use something to compete against the voices, such as music that they like to listen to. Command hallucinations, very important. You guys have to know the importance of command hallucinations. Command hallucinations, this is a disturbing symptom that directs the person to take action. And when the patient has commanding hallucinations, they can't help it. Whatever they hear that voice telling them to do, they feel compelled to do it. They feel, so if they hear a voice telling them to punch you in the eye, they can't stop themselves. They feel compelled to punch you in the eye. So you see how dangerous command hallucinations are? This type of hallucination must be monitored carefully because they may be dangerous. For example, telling a patient to jump out the window or hit the nurse. Command hallucinations are often frightening and may be a warning flag for a psychiatric emergency. It is essential, muy importante, essential to assess what the patient hears. What are the voices telling you to do? The ability to recognize the hallucinations as not real, and the patient's ability to resist those commands. All right, visual hallucinations, those are the second most common hallucinations we see in schizophrenia after the auditory hallucinations. Let's talk about alterations in behavior. Catatonia. This is a pronounced increase or decrease in the rate and the amount of movement. Okay, so they can be moving all over the place, or they may just be still as a statue, depending on that patient's condition. Stereotype behaviors. I'm right here. Repetitive behaviors that do not serve a logical purpose. Negativism. Tendency to resist or oppose the request of wishes of others. Remember the toddler, when the child is in the toddler phase, they have a negativism where everything is no. Even if they really want to do it, you tell them to do something, they say no. All right, negativism, that's what it is. Gesturing or posturing, this is important, assuming unusual or illogical expressions, often grimaces or positions. Let's get into negative symptoms. Again, I can't stress this enough. You guys better know the difference between negative and positive symptoms. All right, negative symptoms. Negative symptoms are serious problems for people with schizophrenia because they are the absence of essential human qualities. Remember, with negative symptoms, it's something you don't have. Positive symptoms is something you do have. So negative symptoms are the absence of human qualities that should be present. Treating negative symptoms is more difficult than treating positive symptoms. Positive symptoms are symptoms that the patient has that they should not. Negative symptoms include the following 6 symptoms that all start with the letter A. Why do they all start with the letter A? A means what? Without, to not have. And remember, negative symptoms are to not have what you should have. So A, they all start with A. Anhedonia, not having pleasure in things you should have pleasure in, or not having pleasure in things that you used to have pleasure in. Evolution, loss of motivation, can't make decisions. Affective blunting, reduced or constricted affect. Okay, and you guys see all the other ones. I don't know why I didn't put a star next to apathy, because apathy shows up a lot as well. Apathy, that's a decreased interest in or attention to activities that used to be important. Nothing makes them happy, nothing, they just have that flat affect. So make sure you guys know those 6 A's. Speaking of affect, additional A word, is an external expression. Oh, let me make this better. External expression of a person's internal emotional state. In schizophrenia, affect may be diminished or not coincide with the inner emotions. So the patient is happy, but you can't see that on their face. Or they're frustrated, they are boiling, but you can't see that on their face. So they might be ready to punch you in the neck and you'll have no clue. So flat affect, that's immobile or blank expression. Okay, guys, I'm going to stop here for part 1. Part 2, we're going to pick up, part 2, we're going to pick up here on self-assessment. So that's the end of part 1 for schizophrenia. Like I said, guys, schizophrenia is very heavy. It's very heavy. This is going to be a multi-part series, so go ahead, buckle up. If you haven't done so already, guys, please like this video, subscribe to my channel, and please, guys, share my content. Help my channel to grow. I feel like I'm the most underrated person on YouTube. Not the most, but I feel like I'm definitely underrated. Help my channel to grow. Share my videos with a classmate or your whole cohort, for that matter, your nursing instructor, someone you know that's in a nursing program. Maybe I might be able to help them. Don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. And I cover nursing content almost daily on my other social media platforms. So be sure to check me out on either TikTok, Instagram, Facebook, or all three. Guys, thank you so much for watching this video, and you guys will catch me on the next video.